welcome everyone to the DOS Postgraduate Education Program. Currently, as you all know, we are in the Retina module. And today we are on the 9th class of the Retina module. And this is the 31st class of the DOS Postgraduate Education Program. And we are happy to have with us Dr. Poornachandra B, who's going to be talking about the topic Hereditary Fundus Dystrophies. So we all read about this topic in our theory books and keep seeing these patients of retinitis pigmentosa and cases of Stargardt diseases, but they are not very common to see. And hence, Dr. Poorna is going to take us through this whole detailed lecture of hereditary fundus dystrophy, how to identify, how to diagnose, and how to manage these patients and how to counsel these patients, and how to prognosticate these patients as well. In your exams, retinitis pigmentosa are often kept as a short case. And often long questions also do come on hereditary retinal dystrophy, which makes this topic really important for the postgraduate students. We are thankful to the DOS, to the entire executive of DOS, headed by our president, Dr. Rohit Saxena sir, our secretary, Dr. Prafulla Maharana sir, our treasurer, Dr. Kirti Singh ma'am, who has taken the lead in organizing these classes, and Dr. Lalit Verma sir, who is the chairperson for our Retina module. Yeah, Dr. Lalit Verma sir needs no introduction. He's taken a lot of time. He's taken out a lot of time to actually decide upon the lectures and to choose the speakers for these classes, which may be useful for all the students. We are also thankful to Dr. Anupam Sachdev sir, who has helped us in having the ANBI collaboration that brings on all the hospitals affiliated with the NBE board to come on a common platform with us, with the Delhi Ophthalmological Society for this postgraduate program. Dr. Ankur Singh is our DOS executive. He is also associated with our Retina module of the DOS PEP and will be present for our discussions on this topic. Our speaker for the day is Dr. Poornachandra B. He's a vitreoretina surgeon and consultant at the Narayan Nethralaya, and he is looking after the Department of Electrophysiology and Clinical Genetics. He has completed his post-graduation from the prestigious Armed Forces Medical College and has done a long-term vitreoretina fellowship from Narayan Nethralaya and has also done a fellowship from the Moorfields Eye Hospital in London. He has completed a preceptorship on age-related eye disease from the Safe Sight Institute, and he is a PhD scholar from the Maastricht University, Netherlands, presented several papers on national and international forums, and presented various articles, and is a winner of various awards at national and international platforms. With that, Dr. Poornachandra, we do welcome you to our DOS postgraduate education program, and we look forward to an enriching class on hereditary fundus dystrophy.
Thank you, Dr. Pranita, for the kind introduction. So I'll just start sharing my screen, and I would like to thank DOS executive committee member and whoever is involved in organizing, especially Lalit Verma sir and Dr. Prafulla Maharana, and of course you for considering me for this lecture. I'll just start sharing my screen. So let me know once it's in full screen mode and it's in. Yes. Service. They need to unmute.
You can just make that full. Yeah, it's clearly visible.
Okay, fine. So, as Pranita was rightly mentioning, the hereditary retinal dystrophies we keep seeing as postgraduates, but we don't see these cases very often. So that makes it even more important to understand this disease. Not only to write theory answers and to answer a few questions in the practical, and also important from the patient management point of view also. So let's try and understand the basic concepts of hereditary retinal dystrophies, why it is important. So before going into the class, I want all of you to understand the difference between a dystrophy and a degeneration. Dystrophies are always inherited, non-inflammatory condition, early in onset. Most of the time it is bilateral and symmetrical presentation. Degeneration, as opposed to dystrophy, it's sporadic, age-related condition, usually a late onset disease. Could be unilateral or sometimes could be bilateral. If bilateral, most of the time it will be asymmetrical. So that's the reason we call AMD as age-related macular degeneration, not dystrophies, because AMD does not follow Mendelian form of inheritance. So before understanding the dystrophies, let's brush up few of the basics about the type of inheritance pattern involved when it comes to inherited retinal dystrophies. So as we all know, autosomal dominant disease manifests if only one copy is defective. All of us will have two alleles, one from each parent. So for autosomal dominant disease to manifest, only one defective copy is enough. Whereas for autosomal recessive diseases, for it to manifest, we need both the copies to be defective. So if one copy is correct and other copy is defective, the patient becomes a carrier and may not manifest the disease. X-linked dominant is similar to autosomal dominant, where only one copy of allele is on X chromosome is required for an individual to be susceptible for the disease. X-linked recessive, again, it's similar to autosomal recessive, but here the interesting fact is, though being a recessive disease, the males, all males will have only one X chromosome, despite having only one X chromosome. So they tend to manifest, sorry, despite this being a recessive disease, all males tend to manifest the disease even if there is one defective copy. Whereas females, most of the time they become carriers unless they carry two defective copies. So that's about the mode of inheritance. So the macular dystrophies can be classified into various subtypes, the autosomal dominant dystrophies and autosomal recessive dystrophies. It's all written there. I don't want to go into all the details and read out the slides. So let's try and understand the dystrophies which affect the peripheral retina. So these includes retinitis pigmentosa, heart-cone dystrophies, choroideremia, and gyrate atrophies. So macular dystrophies, as I showed in the previous slide, as the name indicates, the disease process starts in the macula. So whereas these group of disorders which affect the peripheral retina, the macula remains relatively healthy late in the disease, and the degeneration starts in the peripheral retina. So to understand hereditary retinal dystrophies, it's very important that we should know some of the basics of electroretinogram. I will not go into the details of an electroretinogram because that can be a separate class in itself. I'll just explain basics of fulfilled electroretinogram. So to record fulfilled electroretinogram, first we dark adapt the patient for 20 minutes. In this dark adapted state, when you stimulate the retina with a 0.01 candela per centimeter square of light, we get a big positive deflection, which represents rod-driven activity. There is no contribution from the cones here. In the same dark adapted state, if we increase the stimulus intensity to 3 candela per centimeter square, the A wave starts appearing here. This is called combined response. So there is contribution from both the cones and the rods. After that, what we do is it's called light adapted responses. We make the patient sit in an ambient light or in front of a GAN plate for 10 minutes. In this light adapted state, when you stimulate the retina, what we get is predominant cone driven response. In the same light adapted state, if we stimulate the retina with a 30 Hz flickering light, what we get only cone driven. It's exclusively a cone driven response. There is no contribution from the rods. So if you look at it, we started with an isolated rod-driven response and we ended with an isolated cone-driven response with a spectrum in between. So whenever you do an ERG in a suspected hereditary retinal dystrophies, we need to look at whether the rod component is more affected or the cone component is more affected or both are affected. So I'll take you through some of the case example. So to make you all understand the disease process better. The first case was an 11-year-old male who presented with blurred vision. Visual acuity was relatively good with 6 by 9 vision. When you draw the pedigree, we got to know that this child was born out of a consanguineous marriage, which is quite common in Indian context. So whenever you suspect a hereditary retinal dystrophy, it's very important that you people should draw a pedigree. You should know how to draw a pedigree. So because that will give us a clue about the mode of inheritance, whether it's recessive, dominant, X-linked, or it's not X-linked. All those details can be obtained by drawing a pedigree. So let's look at the fundus picture of this child. If you look at the fundus photo, the disc appears normal, the vessels appears okay. If you look at the macula, the oval reflex is altered and there are some vitelliform-like deposits in the macula. That becomes even more prominent when you do an autofluorescence test. So whatever the vitelliform deposits which was seen on color fundus photograph, now it's more prominently seen on an autofluorescence. So this is the corresponding OCT. You can see there is a presence of subretinal fluid and also an vitelliform-like deposits in both the eye. So when we did an ERG, so first look at the dark adapted responses. It's completely normal and the light adapted responses are also completely normal. So this is a normal fulfilled ERG. But look at the EOG, that is electrooculogram, which represents retinal pigment epithelial function. The bright phase light peak is absent. There should be on peak like this, but it's absent. It's almost like flat. So this indicates it's an abnormal EOG. So whenever you see a vitelliform like deposits with a normal fulfilled ERG and an abnormal EOG, it is diagnostic of Best disease. So it's called Best vitelliform macular dystrophy. And this is the family of the same patient. So if you look at the father, so there is a very subtle vitelliform like deposits in the parafoveal area in the left eye. And the right eye is absolutely normal. So that the disease manifestation can be as subtle like this. So that's the reason we always recommend to screen the family members whenever you diagnose a hereditary retinal dystrophies. When we did a genetic testing, the proband was found to have a heterozygous mutation in BEST1 gene because we know like BEST is an autosomal dominant disease. So that is why one copy of gene is enough to manifest the disease. That's why the status is called heterozygous, suggesting an autosomal dominant inheritance pattern. So it is one of the common Mendelian macular dystrophy, affecting almost 1 in 10,000 individuals. The classic characteristic is vitelliform or egg-yolk-like appearance, and there is 20% chance of developing choroidal neovascular membrane in any of the eye. So there are various stages which have been described for the Best disease. This can come as a theory questions for you and sometimes may be kept in your practical exam either as a case or they may keep OCT or an autofluorescence image. And this becomes even more important if some of you are planning for an FRCS exam and all. There it will be kept in some of in the retina stations. It will go through various stages. One is the pre-vitelliform stage where there is no vitelliform deposit. There could be very subtle RP changes. Then comes the vitelliform stage where you can see classic egg-like appearance due to accumulation of lipopacine inside the retinal pigment epithelium. Once this vitelliform material starts absorbing, what we get is a pseudo-hypopion-like appearance. Usually it happens in second or third decade. In vitally eruptive stage, what happens is the egg breaks into multiple parts, giving a scrambled egg appearance. So it is called vitally eruptive stage. Once all the vitelliform deposits get absorbed, what we see is a predominant atrophy of the RP and overlying neurosensory retina. This is called the atrophic stage. During any of the stage, patients are prone to develop CNVM. So it's not like CNVM is the last stage. If patient has any trauma or secondary CNVM formation, it can form at any stage. So most of the time, the prognosis in Best disease is usually good. The patient tend to maintain 20/20 or better in eyes with undisturbed vitelliform lesion. The visual loss occurs mainly due to secondary complications like fibrosis, choroidal neovascular membrane formation, or central geographic atrophy. And sometimes these patients can have narrow angles and usually they are hyperopes. So it's very important. You need to get a gonioscopy done for these patients. And if it's actually narrow, you can advise them a peripheral iridotomy. So the second case is a 10-year-old male again born out of consanguineous marriage, presented with blurred vision of 6 by 18. He had hypermetropic refraction with narrow angles. So this is the fundus photo. If you look, the foveal reflex is altered, and there is the vitelliform deposit, what you saw in the previous case, which was limited to the macula. In this case, it is quite extensive on outside the arcades, and FFA is also showing some non-specific staining and leaking pattern. Now look at the autofluorescence of the same patient. The vitelliform deposits is seen even more prominently. As I was describing, as compared to the previous patient where the vitelliform deposit was limited to the macula, here the deposit is predominantly outside the macula. And even in the OCT, there is both subretinal and intraretinal fluid accumulation as compared to the previous patient who had only subretinal fluid. So this is a classic case of autosomal recessive bestrophinopathy. So the gene involved is the same. The first one is dominantly inherited and second one is recessively inherited. When you do an electrophysiological test, if you see the fulfilled ERG is also abnormal and there is an absolutely flat EOG indicating a grossly abnormal electrooculogram. When we did the genetic testing, the proband was identified with homozygous mutation in BEST1 gene, so thereby indicating it's a recessive inherited disease. And the proband's unaffected sibling had normal genotype, and parents, as expected, were heterozygous carriers. So this is a very classic example. The gene is same. Once it is autosomal dominantly inherited, the clinical manifestations could be different. Once it is recessively inherited, the clinical manifestations could be different. So this is some of the basic thing what you need to understand whenever you're handling a retinal dystrophy patient. So to managing this bestrophinopathies is primarily of recognizing secondary complications like choroidal neovascular membrane and hastening its aggression with an anti-VEGF therapy whenever it develops. And we should caution these patients against playing contact sports. Protective eyewear is recommended because usually patients with this bestrophin mutation will have a very brittle Brooks membrane. So even with a trivial trauma, this Brooks membrane can give away, giving rise to choroidal neovascular membrane formation. Coming to the third case and the most commonly seen hereditary retinal dystrophies, which can be again kept in your exams also. This was a 26-year-old female with a vision of 6 by 16 both eyes. If you see the fundus, the disc vessels, everything looks normal. If you carefully observe the macular region, macula appears to be atrophic. Again, when we draw the pedigree, we got to know she was born out of a consanguineous marriage, also had one more affected sibling. So this is the corresponding autofluorescence and the OCT. If you look at the autofluorescence, whatever the atrophy which we expected in the clinical fundus picture, it appears more prominent. In addition to these atrophic changes, if you see outside the macula in the mid periphery, there are multiple fleck-like deposits. And if you look at the corresponding OCT, there is outer retinal loss with RP atrophy. So all these are classic of Stargardt's disease, which is the commonest macular dystrophy. When we do an ERG in this Stargardt group of patients, if you try to understand, so let's go by the order. These are the dark adapted response. The blue belongs to the normal person. The black belongs to the patient. This B wave was supposed to start here, but instead it's starting here. That means the implicit time is delayed. The amplitude is also grossly reduced. The same thing can be seen in dark adapted 30 and 30 ERG also. And look at the light adapted responses. Again, it's delayed and the amplitudes are grossly reduced. So basically, it's indicating cone rod dysfunction. That means the cone system is also affected, rod system is also affected. So you must be asking, so why we need to do an ERG in a Stargardt disease? We know classic picture, there is atrophy of the macula, there is plaque-like deposit. Then what's the need for a fulfilled ERG? So these questions sometimes can be asked in an in your exam because one of the stations in DNB and FRCS, even sometimes in some medical colleges and for MS also, they will have a station on where they will give printouts of ERG, autofluorescence, and B scan. And there you may be asked these questions. So Stargardts can be of three types based on the ERG responses. If the fulfilled ERG is normal, then there is a less chance of progression. If only cones are affected, then there is 20% chance of progression. If both cones and rods are affected, as in our case, then there is an 80% chance of progression. So Stargardts can be classified into three types physiologically. In this way, you can prognosticate also, because once you diagnose hereditary retinal dystrophies, you know there is no treatment which we can offer at present. The next question the patient is going to ask is, what's the prognosis? Am I going to go blind? How fast will my disease progress? How should I plan my career? So all these things needs to be told. So when we did a genetic testing, this patient had a homozygous mutation ABCA4 gene, which is known to cause Stargardt's disease. We know Stargardt's is a recessive disease, so the mutation has to be homozygous. So it is characterized by accumulation of lipofuscin in the retinal pigment epithelial cells. Specifically, there is something called A2E or the bisretinoid, which is the major component of lipofuscin, and also on the inner leaflet of photoreceptor and outer segments of disc membranes. So this is a cartoon just taken from the RAND textbook. This is something very important if you want to understand in more in detail about the retinal dystrophies. If you look at this, in a normal fundus, where ABCA4 gene is optimally functional, we will have a normal ERG and normally functioning photoreceptor. If it is partially functional, you will have Stargardt's-like manifestation. If there is a severe dysfunction of the ABCA4 gene, patient can develop cone rod dystrophy kind of phenotype. If it is totally absent, the patient can also present like a retinitis pigmentosa like picture. This is something extremely important when you're dealing with the inherited retinal dystrophies. So same gene, depending on the severity and the mutation involved, the clinical manifestations could be different. Stargardt disease sometimes can have a normal or a non-specific mottling at the fovea. Later stage, it can develop classic foveal atrophy, which is described as wheaten bronze appearance. And there could be varying degree of yellow-white, flex-like deposit, which I showed in the case example. And sometimes can also have bullseye configuration also. Management, currently there is no treatment for this disease. However, there are multiple gene therapy trials which are going on. I'll come to that later. We can definitely give low vision aids and we should prescribe them the dark glasses, ideally the photochromatic glasses. And the most important thing is we should avoid giving any form of vitamin A or aided supplementation to these patients. Because what happens, as I was telling in Stargardt disease, it's mainly characterized by bisretinoid accumulation, which is a toxic byproduct of visual cycle. So once there is a stimulation either in forms of light or vitamin A or any of the aided supplementations, the visual cycle keeps on running, thereby increasing toxic byproduct of visual cycle. So these should be avoided once you diagnose Stargardt disease. Coming to the next case example, and the disease. This is a 22-year-old male who complained with for diminution of vision in both eyes since childhood, had a vision of 6 by 36 and N18. He gave history of severe photophobia. Fundus, however, clinically appeared normal. So when we did an autofluorescence, there was very subtle changes in the perifoveal region, whereas OCT was able to pick up a foveal thinning with subfoveal cavitation, as you can see in the image here. When we did an ERG, if we look at the dark adapted responses, it is completely normal. And same with the combined response. Now look at the light adapted response. It is undetectable. So what you saw on OCT was a small defect in the fovea, but which resembles photic retinopathy. But when you do an ERG, it is telling the cones in the entire retina are non-functional. So this is a classic case of achromatopsia, which is a form of stationary cone dystrophy. Okay, cone dystrophies again can be classified into early onset or stationary or late onset progressive. So the achromatopsia falls under early onset stationary cone dystrophy, which is a good thing for patient because it's not a progressive disease. The patient is born like that and is going to live like that and is not going to go blind. So when you did the pedigree charting, we understood that there were multiple family members who were affected with similar problem. He also had a one sibling who was not affected. He told father also had similar problem. When he did a genetic testing, so there was a mutation in GOCY2D gene, which is known to cause achromatopsia type of cone dystrophy. And if you see, the mutation was heterozygous. That means it is an autosomal dominant inheritance, which you can make out just by looking at the pedigree itself. We went on and tested the father. Father who was affected was also having the same mutation in an heterozygous state. The sibling who was unaffected, this mutation was absent. That's the reason she was clinically normal. So coming to the next type of fundus retinal dystrophy, this was an 18-year-old male presented with blurred vision with a vision of 6 by 36 and a normal anterior segment examination. If you look at the fundus, there was some disc failure. The foveal reflex was not sharp, it was altered. And beyond the fovea and the macula, it's a diffuse RPE degenerative changes. And now look at the OCT. OCT is very classic. If you can see very both cystoid and skytic changes in both the eyes, this is typical of X-linked juvenile retinoschisis, which is very classic. So sometimes you can see these kind of clinical features called vitreous fails, which are nothing but unsupported blood vessels which keeps floating in the vitreous cavity, which can sometimes lead to vitreous hemorrhage also. If you are in doubt, if your the disease presentation is not very classical, you can again do ERG. So there is something, some classic feature which is seen when it comes to juvenile retinoschisis is something called electronegative ERG. I'll explain you. If you look at the dark adopted responses, so in the combined response, the A wave is forming here. B wave, instead of going like this, it's getting terminated here itself. The same thing can be seen in combined maximal response. A wave is forming. The B wave is not even reaching the baseline, but getting terminated here itself. So this is the classic electronegative ERG, what you get in juvenile retinoschisis. The reason being the outer retina is relatively intact. There is a split in the inner retina. The B wave is mainly from the inner retina. That's the reason B wave rise is absent. So sometimes they can ask you people about the differential diagnosis for an electronegative ERG. You need to quote all the conditions in which outer retina is intact but inner retina is defective. Like one is juvenile X-linked retinoschisis, other could be central retinal artery occlusion, and ischemic central retinal vein occlusion, where you classically read about reverse B by A ratio, and some of the autoimmune retinopathies and congenital stationary night blindness. All these group of disorders can have electronegative ERG. And it can be an FRCS MCQ question also. Electronegative ERG can be seen in all except it could be. So read the options carefully. Choose an option where the to rule out all the options by looking at wherein the disease is likely to be make outer retina intact, only inner retina is defective. So managing definitely genetic counseling has to be offered. These cases of juvenile retinoschisis, sometimes topical dorzolamide can be prescribed to bring down the intraretinal fluid accumulation. Laser as an adjuvant or preventive therapy can be used if there are any associated retinal breaks. Surgery is recommended only for the non-clearing vitreous hemorrhage or if there is an associated retinal detachment. As I was showing in the fundus picture, they sometimes can have vitreous veils, which are nothing but unsupported blood vessels. So patient can also present with vitreous hemorrhage. Yeah. Fine. So going to the next case example and the commonest one, which you are likely to get in your exam. So this is that case. So this patient presented with night vision problem and also history suggestive of tunnel vision. So the central vision was quite okay, which is 6 by 9 and N6. And look at the fundus picture. It's very classic. All of you know the diagnosis. So this is a case of retinitis pigmentosa, which is a triad of waxy disc pallor, vastly attenuated blood vessels, okay, and bone spicule-like pigment accumulation. So these are the classic triad of a typical retinitis pigmentosa. If you look here, the macula is relatively spared in the early disease, whereas in advanced stage, the macula also gets affected. So in early stage, since the macula is intact, that's the reason patients can still have 6/6 and 6 vision, but can have night vision and tunnel vision like problem. So this is the corresponding OCT of this retinitis pigmentosa. If we carefully observe here, the photoreceptor layer, that is the ellipsoid zone, which is present just above the retinal pigment epithelium, is present only in the foveal region, and it's completely degenerated in the parafoveal region. So that's the reason they have tunnel vision and night vision related problems. If we do an ERG in these case of patient, just see what we get. Look at the dark adapted response. It's a flat line. It's an undetectable response. And the same in the combined responses also. And light adapted responses are also undetectable. And it is a symmetrical response which is seen in both eyes. Why this? You all may ask me. I know there is no opportunity for you guys to ask a live question here. But since the patient is having 6/9 and 6 vision, but the fulfilled ERG is undetectable. The reason being the photoreceptors, which are present only in the foveal region, are not enough to elicit a fulfilled ERG response. So, if at all, if you want to have some electrophysiological response and if you want to do some study in these patients, you need to do something called multifocal ERG or a pattern ERG. In a case of classic RP, if you do a fulfilled ERG, you are likely to get an undetectable response. You can do this test if the OCT and fundus pictures are not very classic. Otherwise, most of the time, thorough fundus examination and OCT are enough to diagnose retinitis pigmentosa or any other rod-cone dystrophy group of disorders. So next case example is a little interesting. So this patient came to a routine examination. Vision was 6/6 and 6, and he had multiple flex-like deposits. He was totally asymptomatic. He just came for a routine checkup. We did an OCT. If you look at the OCT, the foveal contour were normal. All the retina, inner and outer retinal layers were intact. Basically, it's a normal OCT. We did an ERG in this patient. Again, if you look at the ERG, the fulfilled ERG is also absolutely normal. So what is this case? This is a case of benign fleck retina, which is a familial inherited disorder. But most of the time, patients are asymptomatic, though clinically it looks, pathologic with lot of deposits and all that. The retina is functionally intact and the patients are asymptomatic, and this carries a good prognosis. They don't develop degenerative changes. They will have usually stable course with an asymptomatic profile. This is one more patient, again 6/6 and 6 vision. If you carefully observe the fundus, there are multiple flex-like deposits here also. But this patient is telling, I have a night vision problem. The previous patient was totally asymptomatic. Again, when we did an OCT, OCT was absolutely normal with all the layers being intact. But look at the ERG now. So let's try and understand this ERG carefully. Look at the dark adapted response. It is undetectable. If you look at the combined response, the A wave is forming here. The B wave, instead of going like this, it is getting terminated here itself. The same can be seen in combined maximal response. So this is again a classic electronegative ERG, which I just described in the case of juvenile retinoschisis. Similar kind of a response is seen here also. But here the light adapted responses are absolutely normal, almost near normal. So this is a case of fundus albipunctatus, which is a form of congenital stationary night blindness. So as I was telling, there are multiple differential diagnoses for electronegative ERG. This is one such example because there is some conduction defect in the bipolar cells, because of which B wave will not be forming, and only A wave, the outer retina, will be intact. And we know A wave is from the outer retina, that is photoreceptor. That's why A wave will be normal. And it's very important. These patients will have only delayed dark adaptation, and there won't be any degenerative changes except this plexi deposit. As the name suggests in the diagnosis, it's a stationary problem. Patient will not progress or develop any other degenerative changes. That's how differentiate this from a retinitis pigmentosa. So retinitis pigmentosa patients will also have a night vision problem, but it's a progressive disorder and patient will have tunnel vision. Whereas in congenital stationary night blindness, there are no degenerative changes. They will have night vision problem, but there is no tunnel vision or any other such problem. So this is summary of these two patients, both more or less similar looking retina, but when you do an ERG, it is telling completely a different story. That's why whenever in doubt, when it comes to hereditary retinal dystrophies, always advise an electrophysiological test. That is one more interesting case. This was a 25-year-old male, night vision problem, no positive family history. In fact, this patient had taken multiple consultation before coming to us. So this is a quite rare retinal dystrophy. This may not be asked in your PG examination, but I have seen, I mean, me being coordinated for exam, for FRCS exam. Sometimes these patients can be kept or may ask these questions in FRCS exam. That's the reason I thought of including this case example. So this patient had a vision of 6 by 9 in right eye, 6 by 8 in other eye. Anterior segment was normal. Color vision was normal. Again, born out of a consanguineous marriage. He had one more sibling, was unaffected. So this is the fundus picture of the right eye and the left eye. So disc and vessels are normal, media is clear. If you look at the posterior pole, there is a classic golden yellow reflex. So sometimes we refer to this as a meso phenomena. Even that's what I thought. I thought this is a meso phenomenon, which is seen in some of the congenital stationary night blindness. Oh, I thought, okay, this could be a case of CSMB. So because patient was also telling he has a night vision problem. But when I did an OCT, before that, we did an autofluorescence. Autofluorescence, again, the posterior pole is quite intact. If you look at the periphery, there is a ring of hyperautofluorescence. If you zoom in the posterior pole, there are very subtle hyperautofluorescent spots which are seen in both eyes. The macula appeared quite intact. When you did an OCT, if you see there is a some amount of foveal thinning with skytic changes in the perifoveal region. So once I saw the OCT, I had to revise my diagnosis because looking at the fundus and also the symptoms, I thought this could be congenital stationary night blindness because there was history of night vision problem. There was some meso-like reflex, but these kind of skytic changes will not be seen in CSM. As if you remember the previous case of fundus albipunctatus, where the OCT was structurally intact. I thought this could be a case of juvenile ischemic retinoschisis. Then we ordered an ERG, and I was expecting an electronegative ERG. To my surprise, there was no electronegative ERG. This ERG just suggested both dark and light adapted system were affected, thereby indicating a cone rod dysfunction. So CSMB is also ruled out now because ERG is not showing electronegative ERG. So juvenile ischemic retinoschisis is also ruled out. So what to do now? So when these kind of situation, we do some special form of acroretinogram. So these are for long and medium wavelength cones. What we did was we stimulated long and medium wavelength cones using an orange light by using a blue background. Once we use the blue background in the GANS field, so blue being a shorter wavelength that will silence the short wavelength cones. And in that state, if you stimulate the retina with a longer wavelength like orange light, you can stimulate long and medium wavelength cones, for which there was absolutely no response. Then we did the other way. We used the orange background to silence the long and medium wavelength cones, and in that state, we stimulated the retina with blue light. And what we got was an exaggerated response. So this is a classic case of enhanced S-cone syndrome, which is not very common, but this condition is usually mistaken for some of the inflammatory disorders. They can come, present with macular edema and any other features which can mimic an inflammatory disorder. So ERG is the clincher here. There are a few conditions where ERG, even without doing a genetic testing, we can confirm the diagnosis. This is one such disorder. Coming to the last case, this was a 26-year-old male presented with low vision since childhood. had a vision of 6 by 24 for the distance. Somehow his vision, near vision was okay. He was able to read N6 by holding book close to the face. So this is the fundus photo and the corresponding OCT. In the right eye, if you see, there is an excavated lesion in the fovea. The left eye showed atrophic foveal changes. So when we did an ERG, look at the fulfilled ERG. Though the lesion looks very large and occupying entire fovea, the fulfilled ERG is normal. Just look at the dark adapted responses. Again, it is normal. Light adapted responses are also normal. So basically, this ERG is suggesting the lesion is just limited to the macula and the entire retina is normal. So whenever you see these kind of lesions with a normal fulfilled ERG, these are usually non-progressive condition. This could either be a toxoplasma scar or it could be a macular coloboma. So, and most of these lesions are intrauterine, and from the birth itself, these patients will have extrafoveal fusion. That's the reason the patient vision was relatively okay, like 6 by 24 and N6. If I show you this fundus photograph and OCT, if you ask you people to guess the vision, definitely nobody will tell that patient can have 6, 24 and N6 vision. Fine. So I would like to summarize by showing these three OCTs, which looks like a spectrum of same disease or maybe a pachycodal group of disorder. But the first patient was a case of enhanced Descon syndrome, had a mutation in NR2E gene. The second case is juvenile retinoschisis, had a mutation in RS1 gene. And the third one is a autosomal recessive breast and had a homozygous mutation in BEST1 gene. To conclude, I would like to say dystrophies can mimic both inflammatory and pachycodal group of disorder. A differential diagnosis with other conditions is very important. As I showed in many of the case example, electrophysiological test can be a good adjunct, and phenotypes can vary in presentation, penetrance, and also the inheritance pattern. So this is very important from the patient management point of view. I would like to just end with a couple of slides on gene therapy because this you can get a question in recent advances about the gene therapy. So gene therapy basically it's a technique for correcting effects of defective genes that are responsible for the disease development. There are different ways in which it can be done, where a normal gene is inserted into the cell to compensate for a non-functional gene, or an abnormal gene is traded for a normal gene by recombination, or an abnormal gene is repaired through a selective reverse mutation or a process called gene editing, or we can introduce partially correct copy of gene which is expressed through an alternate splicing or a read through premature stop codon. Or sometimes we may not directly interfere with the gene. There are something called regulatory genes which are just adjacent to the gene of interest. We can also involve them in the gene therapy. So for gene therapy, we use something called AA vectors, that is adeno-associated vectors, because they have very efficient delivery system, very high level of gene expression, and there are no viral genes involved in this one, and they don't cause any significant toxicity to the or immune-like reaction in the host. And the last and the most important point is the excellent stability. They are very stable, so that whenever you manufacture a gene therapy product, they should be stable enough to be transported from the manufacturing site to the site of delivery. Gene therapy is needed in retina because there is an unmet need for IRD patients currently in India because all of us, the moment we see these patients, we tell, there is no treatment. As a physicians or doctors, it's very easy when a patient comes to you and there is a treatment, you suggest, okay, this is the treatment to take. But the toughest situation to handle is when you come across disease for which there is no treatment. So it's very important so that we should start addressing these diseases in the right way, and this is when it happens, it's not only devastating for the patient, but also for the family members. In addition, the presently approved gene therapy product, the only gene therapy product available for the ocular condition, that is Luxturna for LCA, it costs around 6.5 crores. So which we all know, like most of the Indians patients cannot afford. So that's why it needs to be manufactured indigenously in India. It's here itself to limit the cost. We have a dedicated gene therapy production platform out of Narayan Nethralaya with an expanding team of scientists. Just letting you know. So these vectors are produced in something called Class 100 clean room facility. Class 100 clean room facility basically means the sterility is 10 times more sterile than the operation theaters what we use for our routine cataract or refractive surgery. So this is first in India. And if any of you are interested in gene therapy guidelines, and if you want to give guidance to the patient, there is something called National Guidelines for Gene Therapy Product and Development of Clinical Trials, which is available as a freely downloadable PDF in ICMR website. And if any of you come across any retinal dystrophies where you need help in terms of either genetic testing, counseling, or low vision aids, rehabilitation, you can kindly feel free to contact us. So thank you so much.
Thank you, Dr. Poorna, for that wonderful, comprehensive lecture. And I think you've done a wonderful job by giving us so many case presentations and case-based discussion, wonderful images and wonderful pictures of OCTs and ERGs. I'm sure residents must not have seen, such a variety of cases in their setup. Definitely, you've shown beautiful cases. So, just a few questions that have come up. One of the residents has asked, is there any difference in the prognosis of retinitis pigmentosa based on the inheritance pattern?
Of course, yes, it's a very good question. Of course, I'm glad someone asked this question. So retinitis pigmentosa, it's a very loose term which we are labeling it as since many decades. But in present day of retina practice, retinitis pigmentosa is not just a retinitis pigmentosa because there are multiple factors involved. One, as he rightly mentioned, he or she has rightly mentioned the inheritance pattern. So the dominant one usually will have a milder course. The recessive one will have a severe course because recessive ones will have both the genes mutated. Literally, there is no functional protein which is being produced in the cells. And similarly, X-linked will be even more severe as compared to the autosomal recessive. That's the order. And not only the inheritance pattern, it is also the type of gene. So far, we have more than 200 genes which have been discovered which can cause retinitis pigmentosa. Not all genes will have the same severity or same prognosis. Depending on the gene involved and depending on the mutation which happens in the same gene, as I showed in our Stargardt's disease, the prognosis and the severity could be different.
Okay, I think that is why it is also important to make the pedigree charts in the OPD when you see these patients,
Yeah.
even if you do not have access to the genetic evaluation, even a pedigree chart will give you at least a basic idea whether it's dominant or recessive. Okay, so then
True.
another question which has come up with resident has asked that retinitis pigmentosa sometimes presents with, sometimes also have cystoid macular edema. So how to manage these patients?
See, retinitis pigmentosa, cystoid macular edema, there are many treatments which have been tried, starting from topical dorzolamide, oral carbonic anhydrase inhibitors, topical steroids, anti-VEGF. Let me tell you, none of this helps. So none of this helps. So sometimes the retinitis pigmentosa associated CME can be associated with the microinflammation. If you do an angiography, if you see a leak in this macula, you can give a steroid, then only it will respond. Otherwise, we can keep these patients on topical carbonic anhydrase inhibitors because I don't recommend systemic because this has to be put for a very long time and patient can develop renal complications, other systemic side effect due to potassium loss. You can treat them with a topical carbonic anhydrase inhibitors and a TID dose. And if there is an inflammatory component, which you can confirm it by doing an angiography, you can give steroid, then they'll respond beautifully. If it is only due to dystrophic component, the CME, they don't respond to anything. They will have their own course of waxing and waning.
Okay. Okay, so there's another question that a resident has asked that when should we give low vision aids in patients of fundus dystrophy? Should we advise it to all patients, or there are some specific subset when we should advise?
See, the low vision aids, basically, this is only for the macular dystrophy group of disorders because as we know, like RP and rod cone dystrophy group of disorders, usually their fovea is quite intact. Whereas macular dystrophy, the vision starts affecting early. And there is no cutoff once for advising low vision aids, once you diagnose macular dystrophy, the patients, once is not able to cope up with the day-to-day activities, either say reading, seeing the screen and all, they all become eligible and we should advise them low vision aid trials. So that is one thing. And for RP patient, there's a different form of low vision aids in terms of field expanders, either in terms of prism, or there are some Google glasses and some other smart glasses which have come, which can, expand the field of vision. So all patients should be offered a low vision, especially the macular dystrophy patient. So there is no cutoff. You can just, if you can correct with your OPD refraction, the patient can go up to N8, N12, still it's okay. So the moment the patient feels is not able to read and all, definitely should give a trial of low vision aids. And whatever the patient feels comfortable, either the handheld, there are different types of devices which are available. Could be a different class at all. You should subject them for a low vision aid trial.
Okay, sir. Now, another resident has asked, is genetic testing mandatory in all cases of retinal dystrophy, or is it advised in any specific subset?
The moment you diagnose retinal dystrophy in the definition only you told, the moment you label it as a retinal dystrophy means it is following a Mendelian form of inheritance. Genetic testing is a must. So as I showed in many of the case example, the gene could be the same, but the clinical manifestation and prognosis could be totally different. So that
Different.
is very important to what we call it as a deep phenotyping. Because if there is no treatment, we need to prognosticate also in terms of career planning and all that. And the second thing is it will also give us an idea what are the chance of next generation getting affected. So that is the second thing what we can answer because the patient wants to know. They have the disease, they don't want to have one more progeny with the same problem. And the third
Mm.
most important thing is the gene therapy. So there are many genes for which there are trials which are underway. So if the patient is lucky enough to get a mutation for which there is an already trial, then definitely we can tell them. Otherwise, like these day patients are very tech savvy. The moment you tell them retinitis pigmentosa, they will go to Google, they'll put retinitis pigmentosa and read about many things which may not be relevant to their retinitis pigmentosa. Retinitis pigmentosa can be in hundreds of varieties. So once you genotype them and give them the specific diagnosis, this is the mutation. Next time when you Google it, please Google this mutation so that you get information which is relevant to your condition. So that's why there is you need to do a genetic testing. I mean, genetic testing, that could be a different class again. So it's important,
Mm.
it's mandatory. I know it's affordability issue. There are multiple things when it comes to it. But if you ask me whether it's mandatory, yes, it is mandatory.
Okay. As you rightly said, that anybody who's suffering from this disease does not want the second generation to be affected. So, are there any specific antenatal investigations that can be done antenatal or during, the first or second trimester tests that are advisable to identify these diseases?
See, these patients actually, ideally, the moment you diagnose them as a retinal dystrophy, it's better to have a genotype. See, most of the time, it so happens patients come in the 12th week or 14th week of pregnancy. That time, you'll not have much time because for the genetic report to come, that itself will take 3 to 4 weeks. So after that, once it is done, then you should check the spouse whether the person is carrying the same mutation, either in recessive form. So it may happen the patient may be asymptomatic, the spouse, but still may be carrying a recessive pattern. Other gene can be normal, they may not manifest the disease. And we often see such scenarios. That is one thing. Then comes either amniocentesis or chorionic villus sampling. So this you need to discuss with the concerned treating obstetrician. Keep them in the loop. So definitely never advise, any abortion or anything. As an ophthalmologist, our duty is to find out the gene and tell them the chances of inheritance and the percentage to which the baby can get affected. So finally, they need to decide whether to continue the pregnancy. Some people may want to take chance because no, there is something called variable penetrance and expressivity because they may have mutation but may not manifest the disease always. So once we do the chorionic villus sampling and all that, they need to discuss with their obstetrician and take a call further. Most of the time, preferred technique is amniocentesis. CVS is usually not done because chorionic villus sampling that itself can have other
Unnecessary.
complications like limb girdle, this thing, dystrophies and all those kind of
Yes.
thing.
Mm.
Amniocentesis in the first trimester should be good enough.
Okay. Another resident has asked that we frequently keep seeing patients of retinitis pigmentosa in the OPD. How frequently should we follow them up and at what intervals?
It's a very good question. So once you diagnose retinitis pigmentosa, you need to do a baseline investigations in terms of autofluorescence and OCT to for a structural documentation. Whenever in doubt, you should go for a electrophysiological test. At the same time, you should also get a gonioscopy done because we all know like retinitis pigmentosa patients are prone for open angle glaucoma, but that's what literature says. But recently we published even angle closures also common retinitis pigmentosa. Get a gonio done. And also these patients can also have a tendency to develop early cataract. PSC develops early. If you see a retinitis pigmentosa, if it's only retinitis pigmentosa and if there are no other secondary complications like either POAG, PSC, or anything, you can follow them on a yearly basis with a repeat OCT and or fluorescence and physiological as and when required. If the patient has like early PSC and POAG and the follow-up depends on that, maybe 6 monthly, maybe little earlier in case of autosomal recessive bestrophinopathy. As I told, they most of the time they lose vision because of the angle closure glaucoma than retinal dystrophy per se. So otherwise, the general is yearly follow-up unless they have secondary complications.
I think with that, we'll come to an end of the discussion for the day. Thank you, Dr. Poorna, for that wonderful lecture and the uh, the question and answers round. I think that was really good. And
Thank you, Purna.
Dr. Professor, yes, sir.
Thank you, Purna. That was a wonderful talk, and I think you got a huge collection of this hereditary dystrophies. Your pictures were excellent, and I would like to invite you to our annual DOS because this is a very important topic. We can plan a special session on only covering this aspect of retina.
Thank you so much, sir. Thank you so much.
And,
That means a lot. I mean, because that is something we need to create awareness. For some
yes,
reason,
yes,
the
yes.
awareness among even clinicians and retina specialists also very
Very sure.
less about these conditions. It's high time we need to, sensitize everyone so that someone
All these topics must
addresses
be
this to speak
highlighted.
to them. Yes, sir. Yes, sir. I totally agree on that.
I think
Thank you so
consanguineous
much for the
parents
opportunity.
plays a huge role in all these disorders, right?
Yes, sir. Yes, yes.
And it is still there. That is the sad part. I think
Exactly.
Sunil,
Yes, please.
you can play a video. This is all of the students we were asking you when is your annual. So that's it. So we are doing our annual DOS from 13 to 15 June. A lot of students you were asking about the abstract submission. The abstract submission portal will be open by Saturday at max. So and I'll communicate in this group also. And Purna, you are most welcome for our annual DOS, and I'll send you an invitation also. And we can plan a complete session on this. Even you can help me in preparing that because I don't know who all are doing excellent work in this field. And if some international faculty can be invited, that is also we can look into Purna.
Yes, and I can help you with planning the session because we have our core group who are people who are in India who are working on that, and also I mean international faculties depending on the feasibility, even they can be
Please
invited.
prepare a session.
I'll help you with that. I'll help you with that.
You prepare a session, and let me
Sure,
know.
sir.
Then I will
Sure,
surely
sir.
do this session at annual DOS. And
Yeah.
Pranita, if everything is nothing else is there, you can. Yeah, this is a small appreciation from our side.
Thank you
And
so
if
much.
you join us at annual DOS, we'll give you a frame certificate also at our
Sure, sure.
inauguration function. And Pranita, you can conclude.
Yes, thank you, Dr. Poorna, for that wonderful lecture, as we already said, and thank you, Professor, for joining in. And with that, we'll come to an end. And our next lecture is going to be on an important topic, that is myopia and the retinal changes in myopia. So, looking forward to all the students to join for the class. Thank you, everyone, and good night.